nice lunch. Thanks to the CDC Foundation for putting it together. I'm gonna let Laura Lonin kick off the second panel today. And just really what I loved about the first panel was the exchange we had with state, tribes, and local health departments and others, just asking for those concrete strategies. So I think for this panel, I just encourage folks again to come up to the microphones and ask this question. Turn it over to Laura.
Good afternoon, everyone. I'm really delighted to be, oh yeah, I didn't get a good afternoon back. Thank you. So we're very, very pleased to be part of this summit. We thought the morning sessions were fantastic, and we're hoping to keep that good energy going this afternoon, especially since it's after lunch. So we're gonna charge right into it. We also like the flow of the meeting so far because starting with partnerships makes so much sense. We're going to sort of narrow it down now and talk a little bit about organizations. I'm here. My name is Laura Lonin. I'm the Senior Associate Dean for Academic and Student Affairs at the Gilling School of Global Public Health, UNC Chapel Hill. And I am also here with a great group of panelists. If you could raise your hand as you call, Suchi Ayala. Dr. Ayala is a professor of public health at San Diego State University. She's got a wealth of experience in all kinds of organizational settings, and especially with the Latino Hispanic communities. And she'll be talking about small food stores and social service organizations as organizational settings. Dr. Lori Carter Edwards is Assistant Dean for Community Engagement and a professor of health system science at the Kaiser Permanente School of Medicine. She'll be speaking specifically on faith-based organizations. Dr. Paul Esterbrooks is the Associate Dean for Community Engagement and Professor of Health and Kinesiology at the University of Utah. His special focus today will be on work sites. And Kelly O'Brien is the Vice President of Prevention at Us Against Alzheimer's, where she is strategic lead, developing working relationships with business, healthcare policymakers, and family. So, terrific group of panelists. I am actually serving as in a dual role as the moderator and also a presenter. And I'll be speaking first about why organizations, and then secondly, a little bit on some work that I've done the last 20 years in beauty salons and barbershops as unique organizational settings that might be really appropriate for focusing on dementia risk reduction. So without further ado, you've heard a little bit about our panelists. I'm going to get us started. Intervening with organizations. Why should we be thinking about organizations after that great talk this morning about partnerships? Why think about organizations specifically? Well, we do know that the prevalence of dementia risk factors, at least 2/3 of all Americans have at least one of these risk factors. So intervening in organizations reaches people where they live, work, pray, socialize, and play. So that's one factor. We can reach folks within organizations, and we can do it on a little bit more confined basis, if you will. There are also important targets of intervention. We have introduced this spectrum of prevention you've seen from some of the morning slides. We are going to be talking about organizational practices, but it's really important to be aware that as we go through these levels, if you will, of prevention, that the interventions that happen within organizations, they work independently in the organizations, but they also work synergistically. And you're going to hear some examples today about how working within these organizational settings also spills over into other partnerships, other community efforts, other individual efforts, and so on. And so engaging in more than one level is expected to yield better outcomes. So this panel is going to be addressing these kinds of questions. So if you're sitting there and you're thinking about your work at home and what organizations you might want to pursue, I would ask you to just think a little bit about these questions, and we're going to try to answer some of these as we go through our session this afternoon. So why focus? We talked a little bit about that. Who patronizes certain organizations? Are they the target population you're hoping to address? Who will you reach if you actually do approach certain organizations? Which organizations should we be engaging with? How do we recruit them or convince them to work with us. That's something that you started to get into with the partnership this morning. I think we need to think about that for organizations. What are some of the examples of evidence-based or evidence-informed programs, policies, and practices we can deliver in organizations? And what should we be measuring? And how will we know if we're successful? So first, just a little bit more on why focus, not just reach. You can reach a lot of folks there, and they don't have to come to you. You can go to them. Organizations have shared norms and practices and policies that can be influenced in support of health. So that's one leverage point. Also, if you get the right organizations, you have leadership that may support and actually even incentivize change. And that implementing interventions is potentially less complex and more cost efficient within an organization than it would be trying to get the entire community all at once, right? You could start with organizations, have some success, and then move on. And then finally, measuring multi-level change within organizations is possible. And also you can measure change over time, perhaps again, more cost efficiently. So which organizations should we be engaging with? There's many organizations, and I really like the example this morning about folks saying there's differences between rural and urban and suburban areas. So how do you decide what kinds of organizations you might want to approach, given your specific situations? Well, rural areas may just have fewer organizations. So you got to think about what organizations are in your community. Some organizations are part of larger networks you can tap into and really influence. So retail stores as part of larger corporations, for example. Which organizations allow for more interaction with patrons? So some organizations that you might approach, actually you have time to talk with the patrons who come to those organizations about dementia risk or do interventions in there. Others, they're not as well suited for that kind of work. So you want to think about that, right? So is there time and opportunity to really talk with the patrons? Is promoting health consistent with other messaging at that location? There's some places where it wouldn't be great to go into that organization and try to do some kind of health promotion at that particular organization. So, and another benefit of organizations and thinking through organizations would be selecting specific organizations based on populations you're trying to reach. So for example, I'll share some examples about barbershops. And we work in some Black barbershops. We also work in beauty salons and barbershops with other folks of different race ethnicities. But you can do some special targeting in some organizations. The tiendas, for example, you hear from Suchi about that in the Hispanic community and the Asian markets, for example. So organizations we might want to consider, and you'll hear about some of those today, but just to get you thinking about what kinds of organizations might be suitable for doing the kind of work we're going to be focused on in dementia risk reduction. Grocery stores, thinking about food access, recreation centers for physical activity, workplaces where you're reaching a certain segment of the population, faith-based organizations. You'll hear more about that from Dr. Lori Carter-Edwards today. Beauty salons and barbershops, other organizations, public libraries. I'm working with a partner in DC doing laundromat work right now. So thinking about different settings that are in your community that might be appropriate. And there's many different types, right? So what you want to ask yourself is, who attends these places? Are they who I'm trying to reach? How often do they attend? Can you get reinforcement of messages over time? And is there time, opportunity, and patron interest in receiving health information or resources or programming in those particular settings? So how do we get organizations to work with us? Well, that's the million-dollar question, right? And you were asking some of that on the partnership session earlier. So recruitment of organizations takes time and effort and is often underappreciated. So first of all, just getting your foot in the door, finding out who the decision maker is, can sometimes be very challenging. If you have a foot in the door, that's excellent. You want to ask yourself, what's in it? And I want to underscore this. What's in it for this organization to participate with me? How will they benefit in helping their patrons reduce risk to dementia? What's in it for them? Anticipate their response and be ready to respond to that question. Ask them why. Why are you interested or motivated to think about dementia risk? And it often can be a very personal story. Listen carefully to that response of the decision maker and try to respond. It might be that personal experience. It might be something totally different. But if you listen, you can then come back with some kind of response that'll be helpful. And then approaching organizations through personal contacts, advisory boards, professional networks or associations or other testimonials is another strategy as well. So what are the key measures when evaluating interventions? Just a word on this, and we can talk more through examples as you go on. I would just encourage us to think about selecting appropriate and measurable process measures. So when you're intervening in these organizations, measuring the amount of the intervention that you're delivering, measuring the number and type of patrons who receive the intervention, measuring the amount of engagement they had with your interventions, and assessing the fidelity or the quality of the delivery of the intervention. That will give you so much great information to figure out why did you get the outcome you did. And then with regard to outcomes, making sure it's realistic. Are you delivering a dose and intensity of an intervention that's going to make a difference with those patrons? Do you have enough time to actually deliver something in a quality way? Have you assessed the important intermediate steps to making behavior change? That's another set of variables you might want to take a look at. Okay, so be sure to select measures that look at the organizational change. In a workplace, are you influencing any of the kinds of outcomes they're hoping to achieve with their own workers? And consider some of the variables in the REAIM framework. How many of you know about REAIM? I know at CDC this is well known, and I know Paul does because he's worked a lot in this as well. But I really like the REAIM framework for thinking about measurement. And it allows you to compare interventions across organizations and evaluate them. So who are you reaching? Is it who you're trying to reach? Or is it just the worried well folks? Being effective in producing the intended outcome of interest, is it able to be widely adopted by different types of groups and organizations? And is the intervention consistently implemented so that at the end, if you didn't really implement successfully, that tells you that your test didn't work because you weren't able to deliver it in the way you had intended. So it isn't that it was a bad outcome, it was just a bad delivery of the program. And there's reasons for that, of course. And then you want interventions that can be produced and replicated and have long-lasting effects. So you want to choose interventions that really have these characteristics and then measure accordingly. So let's just take the example of the beauty salons and the barbershops. I've had a partnership in North Carolina for the last 23 years with beauty salons and barbershops doing all different kinds of intervention work. Why do I think beauty salons and barbershops might be great for thinking about dementia risk reduction? First of all, it doesn't matter what type of community. Think of your community right now. These shops and salons are in every community. They're urban, rural, suburban. It doesn't matter where you go. And there's lots of them usually. Customers come in and they frequent the shops and salons often for a minimum of 30 minutes. It could be hours that they're sitting, depending on the services being provided, for real. That there's also a loyalty factor. So the customers are coming back on a regular basis. And it's been a historically safe place. So especially in the Black barbershops and beauty salons, that's a place that has amazing history, where it's a safe place to talk about anything, politics, anything, literally. And so having a safe space where folks can talk about something like risk for dementia I think would be a really terrific idea. So just one slide that sort of captures the approach that we used with beauty salons and barbershops. And it was a series of projects. It was definitely a community-based participatory research approach. Okay, so we started with, is there any reason to think we might want to promote health in these settings? So this was now 20 years ago when now there's a bunch of interventions in beauty salons and barbershops. But when we got started, we were saying, is this a good place to promote health? And we had an initiative in Rhode Island at the time. And then I moved to North Carolina and didn't know a soul. And we did get affirmation in Rhode Island, at least, that this was a good place. And we had a whole intervention on creating smoking policy and cessation opportunities in the beauty salons. So I took the idea to North Carolina. And then the first thing I did was get an advisory board to help us, work through this question. And then we basically asked a series of questions and did little pilot projects and brought the data back and talked to the advisory board about what they thought. So the first question was, is it a good idea to think about it? And we got a survey of the licensed stylists, and there are articles here that you can look up and read all the details about what we learned. Then we asked what kind of, and the stylist said yes. What kind of health topics should we consider promoting? And we went in, I had a master's student that went in with us to do an observational study in 5 white and 5 black beauty salons in the area. And we looked at differences. We looked at what they were talking about, and we coded all that. We actually took a look at who's initiating the conversation to give us an idea about how we could actually build an intervention that would respect and honor what was going on in that setting. And I think sometimes when we do interventions, we're not thinking about how to make it fit for that particular setting. So we took time to do that observational study. And then we asked customers, would you be interested in receiving information in the beauty salons and barbershops? And we also did some focus groups with customers, again, finding out that, yes, they were interested in that. And then we did a pilot test. Is it feasible for stylists to deliver specific health messages and programs in their salons? And we got a very resounding yes. That initial pilot study, had just a pretty simple campaign intervention. It had stylist training workshops, which were lots of fun. We brought the stylists in together to learn and talk about messaging. We did displays in the salons. And then we actually had some targeted health magazines that featured our stylists and their customers and so on in the actual stories that we did in these magazines. It made them really fun and interactive. So after we had the success in that initial pilot, we actually have then, since then, developed a whole series of research studies, which are really applied research. So it's very practical. And we did studies next, after we took the results to the advisory board. They said, we want you to come into the barbershops. And so we moved into the barbershops next. We have these series of studies. I'll be happy to talk and answer questions about that. We talked with the participants after to continue to learn about how they would like to see different interventions roll out with us. And that's been the evolution of the work. So these are the kinds of projects that we have done. We've done these topics. All of these are very consistent with risk reduction for Alzheimer's and dementia. So I would just think it would be a perfect way to continue this work. And there's actual 2 reviews that we've done on salon and barbershop-based interventions that you can take a look at to get more of the evidence for this work. And then I'll just wrap up by saying, addressing dementia risk makes sense for me in the beauty salons and barbershops because we'd want to appeal to the salons and barbershop owners as small business owners and community-minded individuals, which they are. This can enhance their business and value-added benefits for them, make a special effort to focus initially on the health of the stylists and the barbers who are really interested in their own personal health and then can relay messages on. And very few health topics are off limits. So I actually really think this would be a good fit. Any questions about that? Be happy to try to answer those during the question time. Meanwhile, I'm going to turn it over to our next presenter, Dr. Suchi Ayala, who's going to talk with us a little bit about her work.
Buenas tardes. Good afternoon, everybody. Thank you for having me here. Laura, thank you for organizing this amazing panel, and to all those involved in organizing the summit, thank you very much. As a prevention scientist, I really appreciate the upstream perspective on promoting the concept of brain health, which is new for me and I'm actually struggling with, so I'd love to talk to someone about that. So today what I'm going to do is share our efforts to promote health or reduce risk in 2 organizational settings. One setting are limited assortment ethnic food stores for the promotion of fruit and vegetable consumption. And the second organizational setting are social service organizations to promote physical activity. And I have 4 takeaways that I'm going to share with you from that work. To set a little bit more of the context, so limited assortment ethnic food stores, the ones I work with, as Laura mentioned, are called tiendas. Limited assortment ethnic food stores are very prevalent, particularly in low-income communities. They function from an intervention perspective, they function fairly independently. They're usually family owned. So there isn't corporate involvement, which has limitations in terms of scale up, but has fewer limitations in terms of the innovation that one can introduce in that setting. There are few distributors, and most of the distributors are unhealthy food distributors. Frito-Lay, Pepsi-Cola, similarly are those involved. As such, they're a source of a lot of products that are high fat and high sugar. So you kind of wonder, are these the places that we want to work with? They are. And the reason for that, very similar to other organizations, is that they're visited very frequently. So unlike what we see in terms of major stock up occurring maybe once a week or maybe even once a month, depending on how people are paid, they're more likely to be frequented for meals to prepare that day or the next day. What we've found across a number of studies is that about a third of a family's food basket is purchased from these locations. So it's a meaningful source of food. And what we learned really interestingly from work in San Diego is that you can actually meet your healthy food basket needs for fruits and vegetables at a cheaper price without really a compromise in quality. Now, I will admit that this is probably more likely in Latino tiendas and maybe Asian markets as compared to other limited assortment food stores you might see in other communities. And finally, in new immigrant receiving communities where I have worked, limited assortment ethnic food stores are a source of social support, as reflected in this quote from a manager. So they provide emotional support, informational support, and a source of a social network for new immigrants into a community. The second organization that I'll describe, these are social service organizations, and we work with them to promote physical activity. Here are just 3 examples of organizations we work with in San Diego, all with somewhat different missions, but really what we learned through exploration was beyond their stated mission are structures and partnerships that they support. So Casa Familiar was addressing the housing insecurity in the San Diego area, and they run 2 large housing complexes, and they have large gyms that we were not aware of, that were not being used. Chula Vista Community Collaborative and the MAC project both had really strong partnerships with schools and with the City Parks and Rec Department. So with that context, let me give you 4 takeaways that we took from working with both limited assortment food stores and social service organizations. So the first one, very similar, I think, to what was mentioned numerous times in the first panel. My first takeaway is involve diverse stakeholders. And for me, diversity is represented in the levels of hierarchy within an organization. And so I'm trained as a clinical psychologist, so I acknowledge being trained probably a little bit more in learning to listen. And so that's what I do when I go into these contexts. And if you look on the right-hand side, you'll see some quotes from some store people. And I think the one thing that I learned was the second quote in particular, and this came from a store liaison, somebody that the manager had put in charge of our work with us. And he said, don't use fancy clamshells because people will think you're wasting money. And so here we thought, let's respect the community, let's get them something that they like. And if you put it in that, they were not purchasing it, but if you put it in a little baggie, cut up, then they would purchase it. On the right-hand side, you'll see some quotes from social service organizations, and I also appreciated the bottom one. You'll see in a moment that we started this work thinking we would capitalize on the beautiful weather in San Diego, but actually what our community partner said and the social service partner said was that we don't want people seeing us exercise. So please find us something without windows, with 4 walls, so that we can feel comfortable moving around for the first time. Relatedly, is anticipating unintended negative consequences. So when we first started this work with social service organizations to promote physical activity, as I mentioned, we thought this is beautiful weather, we've got a lot of great parks, some neighborhoods that are more walkable than others. And so we went with that knowledge and had done a lot of formative research. But then when we started actually implementing the intervention, we found that that was not a good organizational fit, neither for the organization or for the community. And so really using strategies such as implementation mapping to better understand how to fit this evidence-based intervention into the organizations themselves to better meet their needs as well as the needs of the community. The program model evolved into one in which social service organizations were trained on how to identify the best places for indoor physical activity, and then also to engage community health workers. Many of you are probably aware of this strategy, working with promotoras to lead group exercise classes. The promotoras then did what they did best, and that is to promote healthy options that are relevant, accessible, and appreciated by the community. When the program model was in full swing, we had about 47 weekly group exercise classes being delivered across the city, mostly in the elementary schools and park and recreation departments that were part of the partnerships of these organizations. So we were able to achieve some changes through this effort, including lowering systolic blood pressure, reducing waist circumference, improving measures of fitness, and decreasing depressive symptoms, which is something we didn't fully anticipate at the time. Okay, my third takeaway message is to consider changes to the physical and the social environment. You'll see on the right-hand side, I'm sure all of you are very familiar with the social ecologic framework and the strategies that we've all started to implement in terms of trying to change the physical environment. What we have learned is that we have been neglecting the social environment across levels. And so pulling out the social influences from just thinking about it at the interpersonal level and really thinking about it at all levels of influence. So going back to the work with the grocery stores, the tiendas, physical changes that we were able to institute were infrastructure to support the sale of fruits and vegetables, modifications to the butcher department, and modifications to prepare food. Why were those two particularly important? These tiendas, particularly in new immigrant receiving communities and where I was doing this work in North Carolina, the community is dominated by men, and so they are actually the ones that are doing more of the purchasing. We also did a lot of work in terms of the evolutions of these stores, and it's one of the first departments that goes in after the produce section, no matter how small it is the butcher department. It's actually that individual is a really strong source of social influence and change. We sought to influence that social environment by engaging employees in the change process, partly to implement changes in the physical environment, but also to serve as behavior change advocates. And then we tried to target both the physical and the social environment through typical point of purchasing, as well as food demonstrations. Food demonstrations were harder to maintain, but we know that they're really important, especially in this community, because they can't afford to buy food that's going to go to waste. So they have to taste it before they're going to bring it home. So what did we find? If you can read on the left-hand side there, we found that in the study in North Carolina that we did see an increase in overall total servings of fruits and vegetables. This is all based on a cluster randomized control trial, so we randomize stores and then evaluate changes at the customer level. Interestingly, in San Diego, when we replicated this work with a much larger number of stores, we actually found only changes in fruit, and it was only among men, which was really interesting for us. So lots more to be explored there. We also wanted to look and start to see the ways in which the physical environment is changing to better understand how is it that the physical environment changes could potentially impact one's dietary intake or what one is purchasing. And so what we found here is in that first model, if you look, I think it might show there, in the first model, definitely just introducing more varieties of fruits and vegetables. Most of these stores had only about 4 or 5 different varieties, standard things, and ones in the Mexican predominantly diet. But increasing increasing the variety definitely increased the amount of fruits and vegetables that were being purchased, the dollars spent. But interesting what we found, because we work with the stores to try a couple of different strategies. If you're used to going into limited assortment food stores, they're very crowded because they're trying to sell as many different types of products as possible in a small amount of space. But actually what we found in model number 3 is that using existing displays for fruits and vegetables versus adding displays was predictive of increases in fruit and vegetable purchasing. So just a word of caution that sometimes we want to introduce more displays, but it's actually better if you can shift what's already there to make it seem like more part of the environment. And there is some evidence from marketing research that environments that are too crowded will lead to confusion and not necessarily the same type of purchases. Okay, my final take-home message is to really try to inform sustainable evidence-based practices. So if you got a sense from the El Valor, the grocery store study, it was complex. We were trying to intervene in a lot of different places. When we got to the maintenance phase, it honestly was hard for the stores to maintain. So we were really interested in trying to understand what could we do differently. We shifted with money from the Robert Wood Johnson Foundation to try and understand a little bit more about purchasing and placement and marketing of unhealthy foods. And we learned from that process through observation as well as surveys that product distributors support them, right? So the Frito-Lay distributor in San Diego in some communities comes every single day. And they have told me that they are the top store that sells in all of California. So this led one of my colleagues to develop the Bright Side Produce program, which you'll see the website there. And the idea here was, let's take the tactics that the unhealthy distributors are doing and bring those distributors to you. So instead of you're having to go out, then we'll help you make sure you have those stocked. So in closing, I just wanted to share, in terms of engaging either type of partner, appealing to their sense of community is really important. I think we've all heard that connecting the benefits to their mission. And also don't forget that you're working with people. And I think we've heard that today as well. Most of the store owners have themselves experience with diabetes, heart disease, obesity. And so as one of the store manager said, a business is based on customer loyalty, not just to my store, to my employees. My employees are the community. If we don't do something now, and he was referring to obesity, I'm going to lose both employees and customers. So in his mind, a healthy employee was a healthy community and a healthy organization. Thank you very much.
Okay, thank you, Suchi. That was great. And we heard about the ecologic frame, and you're going to see in the other organizational work that people are working at different levels and are influencing different kinds of risk behaviors. So kind of keep in mind what you're most interested in for the question and answer. So Paul?
Great, thanks Laura, and thanks for having me here today. So I'm going to just jump right in, knowing that I've got 12 minutes for a 14-minute talk, the usual. So I'm going to, as I said, I'm going to just jump right in. I'm not going to talk a whole lot about risk factors related to dementia, with the exception of saying that there is strong definitive evidence around weight loss in midlife in the prevention and risk reduction in dementia. I know we had a little conversation earlier in one of the talks that talked about the complexity of obesity, and it's there, but at midlife we have strong and definitive evidence. Which is important because my talk's going to talk about obesity. Okay, so I'm coming at this from the standpoint of dissemination and implementation science. And we've heard a couple of times, just even over the last two speakers, about the way that we develop evidence often doesn't fit within the systems that we're hoping to intervene upon and the people that we're hoping to have benefit from our interventions. And so from a dissemination implementation science standpoint, the work that me and my partners do focuses on, right from the get-go, designing for dissemination, equity, and sustainability. And then when we do adaptations, we also think about what are we adapting to improve dissemination, equity, and sustainability. And that's one of my take-home points. The other thing that I want to talk a little bit about is that with dissemination implementation science, we expand our outcomes from thinking about just what works to reduce risk to also thinking about things like how do we develop strategies to improve the reach of the things that we do? How do we develop strategies to improve the adoption of the interventions that we have across, in this case, workplaces? What are strategies that we have that are related to sustainability? Because all of these outcomes don't come from the same intervention or strategy. The next take-home point that I want to talk a little bit about is what we call evidence. And so as a researcher, we think about what we know about evidence. And in practice, there are often different perceptions. And this is probably more simply put. But when I think about the workplace, we think about the infrastructure that's involved in the workplace. Within there's decision makers, there's doers, and there's people that will benefit from health interventions that we would put in place. And then with each one of these levels, there's different outcomes that can be associated. And I won't go into a deep re-aim talk because Laura's already talked a little bit about it too. And then when you think about these things and we think about our research evidence, typically what we focus on is really pretty narrow. We focus on what's effective in our beneficiaries, what works with employees. In the workplace, when we think about the evidence that comes from the workplace, it's actually a lot broader. Now, often they're not collecting great evidence around effectiveness, but they know a lot more about the infrastructure, about the decision makers, the doers, the workflow, and all those types of things. And so my take-home point here is that when we think about evidence, we should be thinking about an integration of research and practice-based evidence. Okay. So when we think about these types of things where you have different types of evidence and you have a lot of different layers and levels within a workplace or other setting, we think about mechanisms. So what are the things that when we design, how many people took intervention mapping when they were in their public health education at some point? Oh, I thought everyone would raise their hand. So, so I'm going to talk a little bit about intervention mapping, but from a dissemination and implementation perspective. And so when we think about that integration of research evidence and practice-based evidence, we really think about the research side where we're trying to control internal validity, right? We want to take everything and be able to say we can rule out all alternative explanations for what change we had, and this is what we found. When we talk about practice-based evidence, it's typically focused on local impact. And so when we do this integration of research and practice, we really end up with always having a dual primary aim. One is that we want to advance science. The second is that we want to have impact while we're doing the work with our partners, not at some point 10 years down the road, 15 years down the road, but right away. And so when we think across each of these different types of levels, we can think about mechanisms. So from an infrastructure perspective, what would be the mechanism of getting an intervention institutionalized at that workplace and sustained over time? We can then think also about mechanisms of how we would encourage decision makers to determine whether they were going to adopt or not adopt a given intervention. And then the people that would actually do the work and do the implementation, what would the mechanisms of change for those folks be? And there's a good proportion of those that I'm showing here. And then finally, we can think about both from an implementer and beneficiary perspective. What are their values, beliefs, expectations, priorities that we might be able to leverage to help us help them to make changes that would improve brain health? And then across the board, we have the characteristics of whatever that intervention is. And so I'm not going to go through each one of these things, but all of these are mechanisms for application. So I'm going to go through an example of some work that we've been doing you just every once in a while you realize that you're old. But work we've been doing for 20 years. I didn't, to think that I've been doing this stuff for 20 years feels like it hasn't been that long. But we've been doing this, and it's really focused on workplace, and there is some community components to our work as well of scalable weight management interventions that can reach a heck of a lot of people at a very low incremental cost. But we know that we need multiple levels of intervention to actually successfully help people change their behavior, as well as help workplaces change the culture and the policies that they have for health promotion. And so I'm not going to go through our intervention in a lot of detail here, but I'm going to talk about it more from the mechanistic standpoint. So when we start working on this, we often start with, and Marcia Ori, who led the session this morning, talks. I think she was the first one who said, and then you weren't even the first author on the paper that said, begin with the end in mind. What do you want to see? What do you want to see happen? And so when we think about beneficiaries or employees in a workplace where we're trying to improve or promote health, the outcomes we're thinking about are reach and effectiveness and maintenance of changes that we help to facilitate. And when we think about reach, remember, we're designing for equity in addition to dissemination and sustainability. And because of this, we want to think about strategies that will improve the representation and hopefully over-representation of populations that typically don't engage in this type of work. And so if we start with reach and we say, well, how are we going to change reach? We like to start, then we move from the end and then move to a mechanism and say, well, what are things that will help us increase the reach of folks within our particular intervention? In this one, I'm going to talk about our behavioral economics mechanism, which is the second one up there, where we provided, well, I'm going to tell you what we provided. We provided a modest financial incentive to try and nudge people from more preferred, less healthful behaviors to less preferred, more healthful behaviors. And this is a really modest incentive, like $1 per percent weight loss per month. So if someone meets a clinically meaningful weight loss, they're getting $5 a month and they're paid out on a quarterly basis, so $15. So it's very modest, but it's a hook. It's just to help them get over that less preferred into healthy behaviors until those healthy behaviors start to have that intrinsic motivation. And that's the mechanism that we're looking for to try and improve reach. Then when we talk about effectiveness and maintenance, I'm not going to spend much time here because I think everybody's had presentations and talks about social cognitive theory and how that leads to individual level behavior change. So we have a social cognitive intervention that focuses on mechanisms of self-efficacy, social support, and self-regulation. So now I'm going to move to the level of decision makers and doers, when we look here, our outcomes are adoption, just the initial decision whether to use a health promotion intervention or not. And with this one, the mechanisms are really at a different level. It's not about compatibility necessarily for the employee, although we want to think about that. For this, it's about compatibility with workflow. And so you can see some of these mechanisms, and to try and make sure that we have high compatibility with low complexity. And this is a perfect point for me to say, we have a very robust, authentic partnership that's worked on all of this, that since others have talked about that stuff today, I'm not talking about, but if you have questions about it, please ask me. But what we ended up doing was coming up with a packaged approach that allows for work sites to have it's very easy to put into place, so very low complexity. And then from an implementation standpoint, again, we think about what are the things that will help to put this into place. This is another place where complexity and relative advantage is better than other things that we're trying to do. And for that, we use expert external facilitation that helps the work site actually get it delivered, up and running, and then planning for sustainability. And finally, we have maintenance. And in this case, what we found is that observability of results. I think Dr. Carson said earlier that, the data is not that important until you have the good process in place. And that is just so true. Once you have the good process in place, the data becomes super actionable. And so in this case, we want work sites to be able to see that they've been having benefits with their employees. And by having that benefits, they're more likely to sustain the infrastructure and program that's in place. And for us, we use audit feedback on the worksite outcomes that are integrated into our intervention itself so that they don't have to collect extra data or anything like that. So this is kind of very high level types of stuff. I'll give you just very briefly some results that we've had. This is one of our first trials and work sites, and you can see the green bars there are the reach into the employee population with our little modest financial incentive and without. And you can see it had a really, it had a large effect. Even more exciting is this program was 4 times more likely for Black employees to engage in than other racial groups. Then in terms of effectiveness, we present it here. In this case, this is based on some of our partners that they wanted to see the effectiveness relative to the proportion of the overall employee workforce that benefited. And so it's a little bit different than what you might see in terms of magnitude of effect. But you can see again, our intervention that focused on this multi-level, including, all of the different components, was more successful in getting a higher proportion of employees to lose a clinically meaningful amount of weight. And again, one of the things that's pretty cool is in one of our follow-up studies, we found that about 28% of participants overall met that 5% weight loss. But again, for African American participants, it was 35%. So we now have an intervention, and we have such great partners, including Dr. Kiana King, who's one of my key partners over the last 10 years working on this, where we've really engaged the Black community in this work. And it's really shown because we reach more folks from that population and we have better outcomes. I'm going to go through relatively quickly because I think I'm in my 13th minute. But I'll just kind of walk through to say that when we do these types of multi-level approaches where we're designing for dissemination, equity, and sustainability, there's a lot of things that we need to think about, from the strategy, mechanism, outcome process, which is another take-home message, making sure that we're following. If we're going to do something, let's figure out why it's going to work before we even try and apply it. Make sure that we have a good logical reason for doing things. And I'm just going to kind of quickly, like I said, slip through here. We did pretty well with adoption, pretty well with implementation. Maintenance, again, in our studies, we tend to see about 75% of the workplaces continue the program. Most of the times they kind of pull back from the things that are costing them, and they just let their employees continue with our highly scalable components of the intervention. And then the last thing I wanted to say is just that, there's been so much work that's gone on in workplaces, and in particular around total employee health opportunities, that integrating the work that you have related to brain health into existing priorities, existing strategies, is really the way to go. And you can see up here, there's a whole bunch of, I love the work of Nico Pronk, and this is from, I think, one of his papers that shows strategies that have been developed previously and shown success in dissemination and implementation of workplace health promotion. And you'll get questions at the end. And I even had some slides here for you in case I went short.
Thank you, Paul. Dr. Lori Carteret is now going to talk with us about her work in faith-based communities.
Thanks, Laura. Thank you, everyone. It's a pleasure to be here. What I'm hoping to do is to elucidate the practice to research framework. So I challenge us to look at this, instead of starting from our practice lens, from how we can think about going from practice to research. Provide at least, or help you think about one implication for working with faith-based organizations when thinking about dementia risk reduction, and to appreciate the fundamental value in building equity-driven community contextual infrastructures through faith-based organizations. I'd like to give this context by honoring Pastor James D. Gaillard, who is the pastor I work with in rural area in North Carolina. And he and I work together as a result of this practice to research framework. It's how I met him, and we continue to do work together. He basically said that the single most trusted institution within the Black community is the church. It's the only institution with the human capacity and biblical mandate to serve the physical, spiritual, emotional, cultural, political, educational, and financial interests of people. The church regularly assembles people, and the church has built a pipeline capable of being used as a community pipeline as critical needs surface, making it the ideal partner for rapid response. And it's also being used, even if people are not attending church as much as they used to in the Black church. Once COVID hit, all of that changed, and people were going back to these institutions to look for support. He also stated that why the data that churches can actually collect become important. It's the only private structured, sustainable community-based organization in every county in North Carolina where this work was conducted. Average church has hundreds of people attend weekly, and only 10% are there for worship purposes. They're for all the other reasons that we think about. And they become trusted community hubs for doing work with other organizations. His church is one of the largest in the state, also in the nation. So he is a mega church. It actually has over 3,300 members, reaches over 9 rural counties in North Carolina and also across the country through virtual communication. They have a care team of 44 people that are volunteers that are dedicated to reaching the districts within this rural community, the rural communities in North Carolina, in eastern North Carolina. They have a state-of-the-art video and recording studio that is used by also the local community to create commercials. And there's a variety of other things they do within their impact center. And they basically were converted Walmart and took that building and made this church be a community service work. And it's one of the fastest growing churches back in 2013 in the United States. So let me tell you about why I think we need to invest in this practice to research framework. And this is based on work with a series of pastors in different regions of the state of North Carolina, where they came together to come up with priorities that I'll show you shortly. But they also came up with the mission with this steering committee of faith pastors coming together. And their mission for this network was to promote health equity in the communities in North Carolina through strategic partnerships with networks of faith-based organizations and their leaders, not just one, but with networks. And the purpose was to build this sustainable framework and to assess the feasibility of implementing an inaugural F-Bond workshop to build capacity to promote health within this area. The priorities that were identified came from pastors back in 2014. And as you can see, they were interested in some of the same things we're interested in as researchers. Many people don't ask our local faith leaders what they're interested in, but they're interested in data too. They're interested in what research can provide, but they want to play a role in that space. They want to be able to share and disseminate information because they're often tapped into to do the research, but they want to be involved and have their data analyzed the way they want it analyzed to answer their questions. And they wanted to strengthen the capacity of the network because when you've seen one church, you've seen one church. So how do you build capacity together, understanding that each one of them works uniquely? So this was the steering committee and our research team, our capacity building team going from practice to research. And we worked in the area that you see circled in the state of North Carolina. There are 9 area health education centers, regions in North Carolina. We worked within the area L, which also experiences a lot of health issues. And we worked with the other partners that you see there. In this framework for this workshop, we had 17 churches participate, and we had a pastor, a health minister, and a culinary minister participating from each of the 17 churches that came together. And the whole goal was to build this network leadership capacity for them to not just try to address issues in their own organization, in their local community, but how they were going to work together within this 5-county region of North Carolina. So I'm going to quickly go through the different activities we did from 9 a.m. to 3:30 p.m. and we met in one of the counties. We had them do system support mapping with one particular researcher that is at UNC who understands that this was about practice, not about research. That's the reason why we didn't involve any other researchers. The goal was for us to be building capacity. So they did systems mapping themselves as each church did this work for themselves to identify a topic they wanted to address using systems mapping properties. Then the second activity was that they were going to build network cohesion within their county. So we had the representatives from each of their counties get together, and they ended up finding out things they didn't even know about each other, even though they knew the churches existed. So they were starting to identify resources within their counties just by having this opportunity to connect. Then we also had this next activity was they were strategically, oh, excuse me, I missed one. Oh, I missed one. So the third one that's not in the slide deck is they did social entrepreneurship, and Pastor Gaillard talked about data stewardship and how important it was for churches to actually engage in that data stewardship. And then the last activity was the 60-day leadership steps, where we had the kitchen committee individuals got together, the health ministers got together, and the pastors got together, and they collectively talked about their leadership roles and how they were going to move forward. And what they ended up doing is, after that, they had to take with them a sheet to think about what they were going to do in 60 days at their church level, local level, and then in the larger community level. And then I came back 60 days later and asked them a series of questions about what they actually were doing. And so they ended up doing a variety of things, which was wonderful in 60 days, when they got basically a $300 stipend from me to do that work and our team. And so they did food garden boxes. They did walking markers within their church so they can mark a mile. They did feeding events. They did alcohol use reduction, and they also did diabetes interventions. And you see, they also created these community newsletters. So they created their own newsletters with us giving them the template, so that they could share that not only within their neighborhood, but also with funders that they may be wanting to reach out to. Then if you see this next one, the map, the network connections, this is how they connected with each other throughout those 60 days. The blue circles represent additional churches that were naturally tapped into. And then with the governance structure, the pastors ended up creating their own structure of how they were going to lead themselves, with us stepping back. Once we did the workshop, they then created the space to develop their own governance structure. And as you see, we worked with Area L. We had a Trello board where they could find events. They partnered. They could come together. They could do a variety of things. In terms of research, the pastor that's in that picture ended up presenting at a research conference. We had gotten 2 abstracts accepted, even though we had the issue of COVID, but she presented, not me, she presented the work, which was critical for us. And some of us are doing that where our community partners present. They went from 17 churches to 118 churches in 18 months, created their 501c3, created that symbol, and they're now called the Eastern North Carolina Ministerial Alliance, and they go after grants themselves. Thanks. During COVID, we had webinars and seminars that they attended, and we tried to continue that work. But we ended up partnering with Pastor Gaillard, and that's the FAR column. We ended up getting funded for a project, a community engaged risk communication study, and he also participated in the Rapid Acceleration Diagnostics and Underserved Population Study. So they're continuing to do work, even though I'm not involved, and that was the entire intent. I wanted to show you this timeline. I know I have only 2 minutes left, but I wanted to show you this timeline. It took a while to get to this point. I started the relationships with these pastors in the state in 2014. Then I didn't have any money. Nobody was funding this stuff. So basically had to figure out whether this was something to invest in, and listed what the pastor said, those priorities, but then went to the AHEC head and said, need some money. Would you be willing to support this? Sure. Got $20,000, got some support from the Office of Minority Health and Health Disparities. They chipped in, the Institute for Public Health chipped in, and that's what then launched the workshop. And as you can see, from 2019 to 2020, look at the amount of work that was done after building the relationship with the workshop that happened in 2019. And so all of that relationship building led to an acceleration of work that happened as a result of that. And that's the point of going from practice to research. I'll quickly go through this study. We basically created a risk communication study. This was a soft system science, dissemination, implementation, and community engaged research project with Pastor Gilliard. And we reached into 9 counties where you see there. They created the recruitment flyer that you see there, and they are purposely listed on the top. That's the church community team, and the research team is listed on the bottom, and that is on purpose. You need to start thinking about those kind of things. Those small things make a difference in communities. Even though they didn't say that, we made sure that that happened. What you see there is the figure that was the result of the soft system science, where we basically took the work that was done and we created a risk strategy that included a faith element plus the element of trying to address strategies using D&I science. And then they ended up creating an evergreen guide as a result of their work, which was an amazing effort, and we can talk about that later. But in closing, adopting a practice to research framework within faith communities, we know it takes time, but it's a viable approach to health promotion. And identifying champions like Pastor Gilliard, who can be ambassadors for the relationship, not the project. Ambassadors for the relationship, if you're talking about being sustainable, should be the priority. We know that things have changed. We've heard this in our other talks. Systems, peoples, and resources can change, but being adaptable is going to be essential in conducting such work with faith communities. Never underestimate the role of clergy leaders in communities. They're often the first line for parishioner health. They will go to the pastor before they go to the provider, to the doctor first. And we have to remember that. And equitably sharing resources, they got 52% of our budget. We got 48% of the budget because they were doing that work, and we needed to honor that. Last slide. Implications for promoting risk, dementia risk reduction. Think about this. We need to understand the community context. Can't do that unless we elevate them first. Share the road and the roadmap, not just the road. They need to be a part of the roadmap. They need to be a part of this. That's what the practice to research framework tries to allude to. Embracing transformation rather than transaction. We can do all of this work, but if we don't transform how we go about doing this work, we will never get to a sustainable frame. And that's what this is about too. And trust the process of becoming trustworthy. It takes time to become trustworthy. And that acceleration didn't happen overnight. It takes 20 years to become an overnight success, right? Thanks.
All right. And last but not least, we have Kelly O'Brien, Us Against Alzheimer's.
Oh my gosh, I'm so happy to stand right now. How's everybody doing an hour after lunch? I feel like, and also full disclosure, I have to go to the bathroom. So if I'm like wiggling up here, I'm thinking like, oh my gosh, this is just that time of day. So I'm Kelly O'Brien. I'm with Us Against Alzheimer's. It's a pleasure to be here. Matthew and the association, just congrats on a great conference. I can tell it's great because people are chatting in the lunch about all the stuff they're doing and sharing lots of information, and it's really exciting to be a part of it. I want to tell you just a second about Us Against Alzheimer's, and then I'm going to talk about a private sector initiative and the role of the private sector and public health work that you all are doing. So Us Against Alzheimer's, if you have not heard of us, we are a national organization. We were founded about 12 years ago. Like many of us, we envision a world without Alzheimer's, and we focus in 3 areas. We focus on prevention, on early detection, and on access to care. And over all of these pillars, it's really important to us that this is true for everyone. So equity is something that is in our DNA. We were initially founded with networks of African Americans against Alzheimer's, Latinos against Alzheimer's, women against Alzheimer's. The us in Us Against Alzheimer's is really, really fundamental to our work. We're a very small team. The only way anything gets done at Us Against Alzheimer's is with other people. And so every single project that I work on and that my colleagues work on is in collaboration with others. We just couldn't do it any other way. And so we're small in terms of the staff that we have, but our reach is pretty great, I'd say. And it's because we have extended arms. I want to talk for a second about NAPICL 6 because this has been something that has been a labor of love for me and my colleagues and many of us in the community for a number of years. now that Deputy Assistant Secretary Dr. Sherry is not here, I'll say this. I say this with great respect and love for all my government colleagues, but it didn't start out of the kindness of the heart of HHS. This initiative to advance Goal 6 started with a group of nonprofit and private sector organizations who came together to ask that this be done. And it was hundreds of organizations who got behind this. It was not only organizations that were interested in Alzheimer's and dementia, but it was the teachers union, it was Black colleges, it was universities, it was the Diabetes Association, it was the Heart Association, it was the YMCA. I could go on and on and on. And so my point in this is that this Goal 6 is something that we all have a stake in, and it goes vastly beyond people that, like us, that are really focused on Alzheimer's and dementia, but all of these other risk factors see themselves, hopefully, as part of this effort. And it is really critical to the work that I do, and I think to all of us, to think more broadly about the group of people that we work with, which is why this conversation's been really exciting for me today. So we've lots of groups, but each panel in these in the summit is going to talk about different organizations. We've talked about a ton of them today, but I want to note that the private sector, and by that I mean employers, really, really important in this conversation. I've seen a number of charts of organizations that people are working with, community centers and senior centers and all sorts of things, but I would ask us also to consider who is the largest employer in your county, who is the largest employer in your state. And the reason for that is, multifaceted. It's not just that because that's the place where people are, although it is the place where people are, but also because it's the place where people go often, right? Not in every circumstance, but if you're talking about a large retailer like a Kroger or a Walmart, or, there people go in and out, and also people work there. And so chances are that the people, where people live, work, play, pray, that's got to be a critical component of our work. They also have a stake in how their community is faring, because that is their work, that is where they get their workplace, their workers. And right now there is a war for employees. There's not enough. We are struggling with our workforce right now. And by the way, the workforce is aging. And so they have a vested interest in ensuring that their community is both healthy and well and able to work. And the consumers are able to purchase goods and services. And we heard, and I'll talk a little bit about this at a meeting that we had yesterday, healthier people buy more stuff. So it's really, it's just true, right? And so, and employers, they know that, right? If you are not well, if you are not leaving your house, you are not buying things as much. Even in this digital age, that is true. I'll give you an example. This is my favorite example. Everyone's obsessed with Walmart. I'm putting myself in that camp. I heard their CMO talk at a recent conference, and I was just sort of blown away. 90% of the US population lives within 10 miles of a Walmart. 4,000 of their 4,600 pharmacies are in federally designated underserved areas. More than 20% of their employees are Black, 18% are Hispanic, 40% or more over the age of 40. And 5 million people are opted into clinical research. Walmart has a project to help get underserved and minority groups into clinical studies. So think about that. Walmart has more employees than a lot of countries have humans. So, I mean, I think not thinking about them as a potential partner, it's a big opportunity in front of us. As well as others. So these are not mine. I pulled these from various reports, but tried to sort of give to you all some thoughts about the value proposition. You have a lot to offer. Public health has a ton to offer employers. For one thing, just the basics, the things that we just talked about related to the fact that they have a vested interest in having a healthier community, but they also need information and expertise about what their employees may be looking for or needing, and what the statistics and trends are in the community. They need they need data and experts and information in the same way that other organizations do. They are trying to make sure that their employees are coming to work, that they're trying to reduce absenteeism, right? They're interested in consumer loyalty. All of these things are really related to the health status of their community. And so there are things that you have to offer them in terms of information and resources that could be of great service. Also, many large employers in particular have groups of employees, clubs of employees that meet on various things. They're always looking for speakers and information and topics. And they have a lot of need to connect with communities around getting experts to come in to speak. So offering yourself as a service. I was talking to somebody, it was someone in the previous panel who said, if you want someone to serve you or be a part of something you're doing, be of service, right? So thinking about what you may be able to help them with is a really great way in the door. They're also of value to you in the ways that I spoke about, but also because they have political clout in some ways, right? So if there's something that, think about COVID, I have some examples in here, I'm not going to go through as much, but how important the private sector was in that, in what we just went through. And I think in many ways, the COVID experience has made a lot of employers and public health and government agencies more able and willing. It sort of opened a few doors, if you will, because of the necessity of that collaboration. So there's lots of different values that are things that we have to offer each other. These are just some COVID examples. You've all heard of lots of examples of things that the private sector has done in this regard. I remember when, I don't know if it's still existing, maybe somebody in this room knows, but the Biden administration set up a corporate roundtable on this issue when the big employers would come together and meet about this during COVID, right, to decide and work together and to figure out how they could get their employees vaccinated and all of the other things that they did to help protect our public health. So these are just some additional ideas about ways that you can, what kind of things you have to offer the private sector. So this is often the thing that people ask, well, how do we do this? This is not easy. And so I think you should put a public hat on, identifying who the largest employers are, who might have the interest, what are they interested in? I'm again struck by, what are the, Kroger, for example, they're interested in nutrition. So don't go in and talk to them about, we want to talk to you about Alzheimer's, but we want to talk to you about your nutrition work. Think about what people are interested in. Think about ways that you can measure the impact and provide that data back to them. Employers are often interested in recognition, so honoring them for the work that they're doing in the community. And there's lots of entry points, many of which have been talked about. I think local universities in particular have trustees that are often corporate. So if you have a university partner, sometimes you can go that route. United Ways are another great example. Their board are usually corporate. So there's opportunities through different existing partnerships that you may have to reach some of these partners. So now I want to talk a little bit about how Us Against Alzheimer's is working with others to advance Goal 6. A lot of the work here is in the public health space, so you all are here together and working on ways to advance Goal 6 to promote healthy aging and reduce the risk factors for dementia. We are focused with others on building a private sector initiative because we so strongly believe that it's going to be really difficult to meet those kind of incredible goals, reducing the risk factors. I mean, if we could reduce the obesity rates alone in this country, right? So I think, it's going to take all of us, as they say. So we've pulled together a group. We've begun in December to pull together a group of private sector partners. This is just some. There are many others. To conceive of, think about, together with them, build a new initiative to collaborate with the private sector to advance Goal 6 and healthy aging. This is just a high-level sort of visual of the way we think about this. We're going to use this to promote brain health across the lifespan, harnessing the private sector to implement policies and practices that develop and market new products that extend brain health and healthy longevity for their workforce, customers, and communities. And that's a lot. That's a mouthful. But I think there's a commitment through the group, with the group, to really start small and to learn. So we're really with partners. I should acknowledge Sarah Lack from AARP, who's been a really incredible partner with us in this, and the Milken Institute and many others. We're going to start this year by doing a series of roundtables. We did some of those yesterday with groups like Kroger and Shell and Chevron and CVS and a number of others, just talking about what are they already doing, what are they struggling with, Does this resonate with them? What kinds of things could be helpful? What are no starters? So we're really trying to learn. I'm gonna listen a lot this year. We'll be doing a ton of convenings and developing a business plan to move forward. We're going to do this in the spirit of doing while we learn. So our hope is that we will be doing a series of small pilots with organizations, with companies, to help identify successful strategies and really learning from those strategies and from them about what's helpful to them. We already learned a lot yesterday. I was really struck that one of our companies was talking about the motivating factor for them to get engaged in a lot of this work was safety, worker safety. So there's different things that motivate others. This is just a bit about what the future looks like. It'll be on the slides. I'm really running out of time, so I want to be respectful, and some additional resources. So thank you very much.
Thank you, Kelly. Thank you, panelists. That was fantastic. We have lots of time for questions. I know you probably all want to stand and stretch. Feel free to do that. Come up to the microphone with your questions, and we would love to entertain questions from you. You've heard quite a variety of different organizations, different approaches, different ways of motivating groups to get involved in the work that you all are thinking about with reducing dementia risk. I'm going to put one question out to the panelists, but please come up to the mics with your questions. I'm just going to ask one question. What factors do you think were the motivators for decision makers to get involved with you? Some of you sort of addressed this in your comments, but just in a real brief summary, think about what motivated the decision makers in the organizations you worked with to get involved. Who would like to start? Paul.
I think it always boils down to, having a shared priority. So my expertise matching the priority of something that they're trying to change. And, for our work, we often start with a pull strategy where we look for organizations that maybe they have a community health improvement plan that has obesity as one of the top or the top priority. In work sites, the same type of thing. We reach out to different workplaces, and in particular, a lot of times it's smaller and mid-sized workplaces that don't have the big HR and benefits types of departments that really can use the work and energy that a research partner might give them.
This is hard to say as a researcher, but I always enter a partnership telling them that they can quit at any time. It's a huge risk, but they've never quit, thankfully.
Great.
I say the same thing, Suchi, and it doesn't change because the trust is there, but you give them the out. For me, treating them as equitable partners in the financial side and the decision making. Pastor Gaillard has actually told our previous dean that Laura and I had at UNC that he enjoyed working with our team because for the first time with the many researchers he'd worked with, he felt like he was an equitable partner in the process. And he said he had never experienced that before. Someone always came wanting something without trying to know them. And it really made a difference to all the accelerated work that came as a result of it.
I think we're still learning a lot about what motivates some of the private sector players, but I would say the most important lesson for me has been to ask, why are you in this? What is your interest? It's been a little bit different for a lot of companies we've talked with. It's employee engagement, which for them is a marker of retention and recruitment. For some, like I mentioned, it's been safety. For others, it's healthcare costs. But I think knowing what it is that they need in the process from the get-go is, in the short term and the long term, has been really helpful.
Listen carefully, which I did. I think I had it on my slide, but there's so many different reasons why people get involved in this work. And a lot of it, I think, in this particular topic area is going to be personal. And we all have our own motivations for getting involved in this work, right? So, I do think taking time to listen and actually respond empathically to that, and then easing your way into the relationship. And it is relationship building, and I think the partnership folks talked about that in the last session too. Okay, I see that we have maybe a couple people that have stepped up. So Marcia, would you
Hi
start us
there.
off?
Again, it's Marcia Ori from Texas A&M. I really love what you talked about with the power of organizations, but you also mentioned unintentional consequences. And I know from REAIM that's really important. Just don't look at the good things, but look at unintended consequences. So I'd like to know from the panel, how do you handle it when organizations have either perpetuation of stereotypes or misinformation? What strategies do you use to put people back on the right path?
Fantastic question. Who would like to start from the panel?
I think probably the one strategy that has worked best with us is the partnerships with community-based organizations, and specifically empowering the community health workers, because they actually have the ear of organizational leaders in their own communities more than they would listen to me. And so if they're able to dispel myths or stereotypes, they're definitely more effective. And yeah, and there's a lot of perpetuation around not being physically active, concerns around injury. I mean, all kinds of stuff. And it's amazing to me that despite all this work, there's still so much that work needs to be done, specifically around physical activity, because of the perpetuation of ideas.
Marcia, I'd just like a clarification of your question. Do you mean what misinformation comes from the work, or the trust that the community may lag in because they don't understand the researcher's perspective? Those are two different ways to take your...
All of the above, but when you get an organization itself that's perpetuating the myths, like you said, that exercise is bad for you. So I think it's exactly what you said as well as what I thought of you. And your response?
I can tell you that working with the RADXUP, so I'm a consultant, and I do the evidence academies across the country for the RADXUP enterprise. And what we've learned is the same thing that Suchi mentioned. You have to have the champion that has the correct information be the spokesperson to the other organizations. So for instance, with Pastor, I have not yet been to one of the meetings that's held by the Eastern North Carolina Ministerial Alliance, and they will never have me present because I'm not a pastor. They will never have me present. I work directly with Pastor Gaillard, but they can never have me present. So you can't possibly expect that. You cannot think you're going to be the spokesperson. What you have to do is find that champion that can state the correct information, and then let's spread that message.
Yeah, that's fantastic. And I'll just add one really specific strategy to that. In the beauty salon and barbershop work, I was not the primary recruiter either. We had the advisory board, and they recruited for us, but they did it both in person and also via video. So any time you're trying to do really big recruitment, and you can get a video with testimonials or advocacy for your program from some of the constituent groups, it is extremely powerful in terms of a recruitment strategy. And we have some data to support that. So I just would love for you to think about that strategy if it's helpful to you. Okay, next question, please.
Good afternoon, panelists. Anita Balan, American College of Preventive Medicine. I think I may get the second half of the equation from the next panel, but I would like to hear from an organizational practice perspective, what are your thoughts on enhancing the clinical community linkage, because the trust needs to be within the community organizations, specifically for providers who are referring patients to these various community organizations to reduce various dementia risk factors, et cetera. So I'm just trying to hear specifically from an organizational practice perspective on strengthening the clinical community linkages. Thank you.
Would anyone like to start on that one?
So, as a new school, Kaiser Permanente Bernard J. Tyson School of Medicine is a new school, and my role is as the Assistant Dean for Community Engagement. We work with a committee that we've come together with. The committee, we have a community engagement stakeholder committee within the school. We also work with Kaiser Permanente's community health group and also with the managers, the community health managers within the system. There has to be this opportunity for all of them to know what each other is doing to then talk about how they're reaching out to the community. Each one of us actually reaches out to community organizations and try to feed that information back into the KP system. We're doing it through the medical school. Community Benefits is doing it through reaching out to the communities, and the ones who are the community health managers are doing that through the medical centers and through the federally qualified health centers with whom we partner as well. So it can't be just one size fits all. And I hope that answered your question. Okay.
Well, I had the pleasure of co-leading a study that was actually funded by CDC, very forward-thinking in childhood obesity, and it involved community clinical linkages. And probably the best part about that, because we worked with federally qualified health centers, elementary schools, parks and rec, restaurants, grocery stores, to kind of thinking about any organization or a setting that would touch a child's life. And the beauty about that was what became apparent. So first off, there was less diffusion of responsibility. So every time you would go to a new organizational partner, they would always say, well, it's so-and-so's responsibility. And it was nice to be able to say, well, we're working with them to kind of, what are you doing about this? And so through that effort, and it was coalitions that were working together, so there was a lot of really good communication. What we learned that one of the biggest impediments to addressing the issue of child obesity was actually in the clinical setting, because clinicians were reluctant to diagnose with childhood obesity, whereas the WIC counselors were not. And so they really push the clinical organizations that you have to do something because you're making it impossible for us, especially given the authority that clinicians have in the Latino community and the respect that they give them. It's too hard to kind of go against that advice, even though you might be getting the best advice from everybody else. So that was helpful.
I might throw one more thing in that, I think that the clinical community linkages, for them to work really well, clinically, there needs to be resources put towards that. And, hiring in and of the communities that you're working with, whether, really across the levels of the organization. And at University of Utah, one of the outreach efforts that we have that has some of the community benefit dollars, but also additional clinical dollars, is our wellness bus, which goes to the different high-need communities, once a week to each place, and does basic screenings, and then does warm handoff. So social determinants of health screening, warm handoff to resources to try and resolve those. And then we do screenings around lifestyle behavior, prediabetes, blood pressure, and we're working on projects right now that are trying to do warm handoffs with low or no cost community programs, which is also a big issue with the folks that come to the bus. Are, almost 60% are uninsured, high racial ethnic minority representation, folks that could benefit most, but typically wouldn't go to a clinic where, when they're not insured, that they're just worried about cost.
And there's a session just following ours that's going to talk about this too. So I'm really going to be interested to see and hear where those connections are too. So thank you for that question.
Yes, please.
Hi. In some way, this is a follow-up on Dr. Ori's question. We hear so much about the kind of dark side of corporate America, being so focused on revenues and profits, and not necessarily investing in their workforce. Maybe it's true, maybe it's not, but it's in the news a lot. So to Kelly, do you find resistance in large businesses, corporations, organizations pushing back on investing in prevention for something that is pretty far down the road, and that they probably aren't going to be able to negotiate a better rate with insurance, with Blue Cross Blue Shield, because the savings are too far down? Are there the workforce that are getting towards the end of their career? They're more expensive. Some ageism possible in terms of companies not wanting to invest in older employees who might be at the high end of the salary range.
I think that, let me just flip this for a second. Capitalism is alive and well. And I think that it is a mistake for us to appeal to philanthropy end of employers. I think that if this becomes corporate social responsibility, we lose. I think this is about, they need employees. They are struggling with their workforce right now. They are interested in recruiting, retaining, engaging, keeping their employees. They need their older employees to stay and to be well. That's our argument, that this is good for them, not that it's important for them to be good for us. So I think that it requires us thinking differently about our argument and not going to the foundations and we want people to do this, they said yesterday, we want people to do this out of the goodness of their hearts. That's great, keep your good heart. But that's not what's gonna make it sustainable, right? What's gonna make it sustainable is the goodness of their revenues. Let's be frank. I hope so. I think that's what we are hearing from them. And that is why I think about mental health post-COVID. That is not like an option for a lot of employers right now. They have to be doing this work to keep their employees. They're not saying, oh, I'm going to be a good employer. They have to do this. And so I think that's where we're going. And I guess I'm hopeful that that's the case, but we'll see.
Anyone else want to comment on that? Paul?
My experience has been, I think, very similar. And, I can't remember who it was, to give credit, that talked about doing engaged work that is transformational rather than transactional. And, kind of my cynical view on it is when I have had projects where we're working, and in particular with multiple retailers, as employers and trying to get to a common goal, transactional is the only way it works. That this for that. And I think that's maybe not as elegant a way of saying what Kelly said.
And I'll just add one other thing about working with workplaces, which is a lot of my work right now. There will always be employers who are going to say no, they're not ready, they're too busy, they're whatever. Where there is power and where I've seen really wonderful things happen in terms of leveraging is to get some of the key leaders in a community, some of the key employers in the community start talking to each other. Like we held breakfast meetings for employers to come find out about our new initiative. And it had to be breakfast because the rest of the day was not available. But breakfast meetings were super engaging for them. And they actually talked more to each other than they did to us. But they came for something where they could network, they could see other people were buying in. We had, some of our champions talk to them about why they bought in, and it took on a life of its own. So it's kind of, the partnership model that you've been hearing all day so far, but it really did come from them talking to each other, so.
I'll add to that, since I know we talked a lot about evaluation, is also just to build in those measures. I also work with restaurants and helping them see that they waste less food by marketing the healthy products to kids a little bit more effectively was good for their bottom line.
Cool.
Thank you for another excellent session. Would you all, any of you or all of you, speak to organizational practice change with regard to caregiving, supporting workers, and the development of what I think we're now supposed to call an inclusive environment?
Well, I guess I'll just echo a little bit of the conversation. Laura, you can help me. You were at the meeting yesterday about the conversation yesterday, but it was employers are worried about caregiving because their workers are leaving work. And so I think there is an opportunity to have better conversations with them about this topic in supporting their caregiving population, not only through their own workplace policies, but even, I mean, a lot of employers don't even know how many caregivers they have, right? Who are, even just knowing what's going on. So I think there's opportunity there. I also think there's opportunity to think about, again, this is not my own point, I'm taking somebody else's point, but caregivers are an audience that is open and interested in the kind of topics that we're talking about today. And so it's really important to think about their health, not just the health of the person that they're taking care of. So.
Yeah, and the meeting that Kelly sponsored yesterday was with employers and a lot of other big organizations. And that really rang through because the cost of caregiving to employers right now is growing by leaps and bounds, as we all know the demographics. So part of it is we have to be, I think, a lot clearer about what that cost is. And it's caregiving for kids as well as elders. It's the whole life course of caregiving. And so I think there's a lot of really important work to be done in this area. I think people are starting to pay attention to it. So I'm really glad you asked us to comment on this. I don't think we have all the answers yet, but I think the potential is huge for employers to play a significant role. And that was really reinforced by the employers yesterday that were at that meeting. So.
From a faith-based organizational standpoint, the pastor I was speaking with, they have a growing aging population. And so the 44 districts, these are 44 individuals, they have 9 leaders. So they have an organizational structure. I didn't even show it to you. It's mind-boggling to see how they have structured their church. It's a web. And in that space, the 9 leaders that work with the 44, they specifically target our elders, and that's not everyone we're talking about today for our dementia risk reduction is not just elders, but in the space of elders, they have a special program to try to reach them to be more inclusive. For instance, everyone at some point sends them a postcard because they are not necessarily all online because they're in this rural community. The elders get a postcard weekly from someone at that church, no matter what. And they try to stay connected, and they've created other programs. They have silver sneaker programs. They have a variety of programs within the church, but they have made a concerted effort as an organization to do that. Hopefully they're modeling that in the Alliance, but that's from a faith-based organization standpoint. Thanks.
I'm going to steal from Marsha Ori's strategy, and I'm going to ask each of our panelists, since we don't have any other questions that I noticed from the crowd, unless there is one. Did I miss one? Anyone have last questions in the crowd? So just, some of the take-home things that you would like to share, one or two points you'd like to share with the group about working with the organizations. So I can pick on someone, or someone could volunteer to start.
I'll start some at the
Kelly, way to-
end. Yeah. I guess my takeaway point would be to think about this as an opportunity and to talk to people about this as an opportunity. I think we, as people interested, speaking with, including myself here, often think about trying to convince people about avoiding things, stopping things. You don't want to get this. You don't want to have this. You got to do. And I think the exciting thing about brain health is that there's an opportunity to be resilient, to be happy, right? To be more productive, to have purpose. And I think that investing in these sorts of strategies has an incredibly hopeful side. This is not the old school health and wellness days where we're trying to convince HR to just do these programs to reduce their healthcare costs. This is an opportunity for employers, for people to be better, to be stronger, to be more resilient. And so I guess I would just encourage us to think about the upside of all of this and talk to people's better nature and their aspirations as well as their fears.
I would say build a relationship with an organization that is part of a network that can be the champion for change. We don't do the work ourselves, but that champion organization, not the individual, but the champion organization works with a network. And that network can expand the reach, but building that relationship becomes key. Thanks.
I guess I would end with using the terms integration and evolution, that, doing the work that we do, focusing on integration of priorities, integration of workflow, integration of resources, and knowing that everything evolves. So what we design today will work today, and it might not work tomorrow. And so we're going to need to keep focusing on the evolution on how we do this type of work.
See the potential in all organizations. They all have something to contribute. Just got to figure out what it is.
I love all those. Those are great. So I think we heard a lot of things that were really valuable today. I want to thank all the panelists. I guess, if I had to think of one thing, it's the capacity opportunity. Capacity building is really interesting. Not only that we want to foster that in the organizations we work with, but we need to learn from it's a co-learning environment. So we need to learn from them and really tailor what we do to fit those organizations. And I think if we do that, we'll have the partnerships we want to move this whole thing forward. So thank you all for your attention, and thanks again to the panelists. Break? Is there a break? There's a break. 15 minutes. I think back at 3.
Yes, thank you. Yeah.